Good evening, students. This is Dr. Anil Mahajan from Inspiring Minds. Today, we are going to discuss a topic from the medicine, specifically from the gastrointestinal tract medicine, about irritable bowel disease, or sometimes we call irritable bowel syndrome. So, students, before I start to discuss about this topic, I just want you to look at one clinical case scenario, then we will approach to all the information about this topic and we will come back to this again. So here, a 30-year-old female patient complains of everyday abdominal pain and says it gets relieved after defecation and precipitated after meals. Frequent bowel movements 2 to 3 times after breakfast, lunch and dinner, and she notices mucousy stools. Her concern was the persistent abdominal pain. So basically what it says that a female patient which is 30 years old comes to the doctor and she says, "Doctor, I'm having abdominal pain. And now whenever I eat something, whether it is the breakfast, whether I'm taking the meal in the lunch, whether I'm having my dinner, 2 to 3 times she has to feel like she has to defecate. And this pain gets precipitated after the meals." So just look at this clinical case scenario and now we'll discuss about this irritable bowel syndrome. So friends, what basically this irritable bowel syndrome is, it is a functional disorder. It is a functional disorder of the gastrointestinal tract. And always it is manifested as a stress on the gastrointestinal tract. The stress on the gastrointestinal tract, what does it mean? See friends, in our body, each and every organ responds differently to the stress conditions. Okay? Even a human being also responds differently to the stress conditions or everyday worries. GIT, how it responds, just for example, a person has just turned from a vegan to a non-vegan diet. Okay? And another thing, there is a change in the habit of the bowel. Like you are having it everyday worries in the life. Like your day in the office was not good and you are in so much of the stress that your GIT is not able to tolerate it. Okay? So this is a functional disorder. Always manifestation like stress on the GIT. So irritable bowel disease, about the epidemiology, globally, worldwide, the prevalence rate is 10 to 20% and the incidence rate is 1 to 2% per year. So it is quite a common disease if we talk globally, and it is more common in females than males. You understood? So friends, irritable bowel syndrome always, accompanied with any of the functional entities. We can't rule out a lot of many diseases and functional disorders while making a diagnosis of irritable bowel disease. So it is most commonly, it has its association either with chronic fatigue syndrome or anxiety disorder or gastroesophageal reflux disease or fibromyalgia. So the patient has to have one of these symptoms along with this disease. So if I would go for the types of irritable bowel disease, it is constipation predominant, might be diarrhea predominant, might be mixed type. You just need to look at these things and symptoms, how the patient presents. The patient may present to the doctor with the abdominal pain. But friends, in irritable bowel disease, abdominal pain is the key symptom. Make a note, key symptom. Abdominal pain is the key symptom. And most consistent symptom is the altered bowel habits. Altered bowel habits, it says that whether the patient have the episodes of constipation, or the patient is having diarrhea. In the types also, we have written that it is either constipation predominant, either diarrhea predominant, or mixed. So symptoms, the key symptom is the abdominal pain. But most consistent symptom is the altered bowel habits. Maybe the patient is having abdominal distension, constipation, diarrhea, flatulence, heartburns, nausea and vomiting. But nausea and vomiting is not so common. It is seen in 30 to 35% of the patients in irritable bowel disease, or might be dyspepsia. So the basic two symptoms, which is abdominal pain and altered bowel habits, it must be there in a patient with irritable bowel disease. Other symptoms might be present, might not be present. We just need to rule out each and everything while taking the history and physical examination. So before making the diagnosis, I just want you to know that, see, there are a lot of symptoms which are similar to a lot many diseases in any system. So whenever any patient approaches to a doctor, a good doctor has to be that who is not just writing the test, prescribing the test and taking the help of the machines to get to know into a particular diagnosis. The physical history has so much significant role. Even I would say 70% of your diagnosis is based on a physical history the patient would give to you. or how would you approach asking or taking the physical history and physical examination. So while making the diagnosis or to consider, okay, the symptoms are resembling the irritable bowel syndrome. Irritable bowel syndrome can't be there in a patient whose symptoms appeared after 45 years. So any patient after the age of 45 years comes to you with having a lot of these symptoms, you can't make any diagnosis about irritable bowel disease. It can't be possible. The patient is having anemia or weight loss, never possible, irritable bowel disease. Or the patient is having fever or increased in the ESR, you can't make it. Nocturnal diarrhea. The patient, whenever the patient says, doctor, the diarrhea or the constipation pattern is so much, or abdominal pain is so much at the night times also, that I have to get up from my sleep and go to defecate. So it is not, giving us any hint about making a diagnosis of irritable bowel disease. Or large volume diarrhea and blood in the stools. There are a lot many conditions where the patient would say, I have noticed a blood when I was passing the stools, or I'm feeling like abdominal pain along with the blood in the stool. So in irritable bowel disease, you can't see the blood in the stool. Steatorrhea and malabsorption symptoms. Irritable bowel disease never represents with the malabsorption syndrome and steatorrhea. Okay, while making diagnosis, just first know when not to consider irritable bowel syndrome. So what about the pathophysiology part of irritable bowel syndrome? See, prevalence is too much. We know it is quite a common disease, but still the pathophysiology is uncertain. But only many theories have came apart about how this disease is progressing and how the syndrome gives its characteristic features. But still the pathophysiology is uncertain. Some of them says about the visceral hypersensitivity. Visceral hypersensitivity is what? Whenever we take up any meal, whenever we eat any meal, there is, after getting digested and absorbed, there is a particular volume when we start to feel like we need to defecate now, okay, after getting digested and absorbed. But in this case, irritable bowel syndrome, what does the theory says? That the patient who is suffering from irritable bowel syndrome, whenever he takes up only a lighter meal, the rectal pressure is increased due to the receptors present, which is nociceptors. The pressure on the rectum is increased even at a very low threshold. The patient always start to feel to defecate. Even with a lighter meal, which is not even getting 100% digested and absorbed, the patient start to feel defecating, abdominal pain. So patient always has the urge to defecate. And another theory which has come up for this irritable bowel disease is serotonin. Enterochromaffin cells releases one neurotransmitter which is a serotonin, and some of them say serotonin has a relation with this neurotransmitter. So the main pathophysiology is uncertain, but you need to keep in still mind about the visceral hypersensitivity. Small meals causes the patient to have the feel like to defecate, okay, because of the increase in the rectal pressure even at very low threshold. So how to make the diagnosis? So I have told you already, to make the diagnosis of the irritable bowel disease, you must understand the symptoms must not be after the 45 years of age, and a lot many things. Now to make a diagnosis according to the Harrison medicine, it says we need to follow a criteria which is Room-4 criteria. So whenever it is asked in the MCQ point of view, Room-4 criteria is used to diagnose it is irritable bowel syndrome. It says the pain, the key symptom which is abdominal pain. It must last. It must be the person must be having 1 day per week for last 3 months, at least a day in a week, and the person must be having this pain from last 3 months. Or another thing which is included in this criteria is change in the frequency and form of the stool. I told you about the altered bowel habits, which is a consistent symptom, whether it presents with constipation or can present with diarrhea. But always abdominal pain is there to the patient. That's why he approaches to the doctor. That abdominal pain is so much whenever the patient takes up any meal, he or she always feels to defecate. Or episodic cramping exacerbating pain which is relieved by the defecation and precipitated by meals and precipitated by meals. So friends, this is the diagnosis how we can make in irritable bowel syndrome. Which criteria we are using? It is a Room-4 criteria. Before we used to use Room-3 criteria. In Room-3 criteria, abdominal pain along with abdominal discomfort was written. But now in Room-4 criteria or modified Room-4 criteria says only abdominal pain, not the discomfort. The discomfort word has been taken away from this irritable bowel disease. And what is the treatment? So okay, now you understood. Till now, it is a functional disorder which is manifested as any stress condition on the GI tract. Okay, and this association with other diseases. always associated with one or another functional disorder. So treatment, what is it? See, whenever any patient with abdominal pain and these things approaches to you, you ask about a diet also while taking the physical history, an examination. So, friends, there is one kind of diet which is FODMAP diet. FODMAP diet means fermented oligosaccharide, disaccharide, monosaccharide, and polyallols. So this is basically a diet which is rich in fructose. So you ask whether you are taking any meal which is rich in fructose. There are certain foods actually. You can have a look at it. There are certain foods which are rich in free fructose levels. So we always tell those patients to stop taking those foods or decrease the quantity whatever you're taking. So we need to tell first thing is stop having or decrease FODMAP diet. Because what happens that these foods are these kind of food are rich in fructose sugar. Whenever you have these kind of meals which is rich in fructose, it gets digested, absorbed, and goes to a small intestine. The small intestine, whenever there is a rich in fructose, it withdraws, the water from it, and it goes out as a diarrhea and shows the characteristic symptom of diarrhea. And in the large intestine, we have our bacteria present, and those bacteria, act on this kind of food and produces a lot of, acid and symptoms of having gas and constipation. Because of this fermentation kind of product, a lot of acid has been produced, and gas, flatulence, and constipation symptoms can occur. So first thing in the treatment, you have to make sure the patient is not going to have this any kind of food which is rich in FODMAP diet. Another thing, I have told you about the types of irritable bowel disease. If it is constipation predominant patient has approached, then first thing FODMAP diet. Okay. Then if the constipation patient has come to you, you have to prescribe psyllium husk and peg laxative. See, psyllium husk, it's a kind of dietary fiber which adds a bit of fiber in the diet. And another thing is peg laxatives. What it does, it causes softening of the stools. So along with the FODMAP, psyllium husk and peg laxatives, the patient after some time, the symptoms would get relieved, and he or she would say, okay, the symptoms of the disease has been vanished already. But if it is still occurring, then you need to go for the drugs. And the drug we need to prescribe it is lubiprostone, which is basically a calcium channel activator. Okay, lubiprostone we need to prescribe in the patients having irritable bowel syndrome, which is constipation predominant. And now, if the patient has approached who has irritable bowel syndrome, which is diarrhea predominant, okay, first thing you need to always FODMAP diet. You need to tell the patient stop taking those food, which are rich in FODMAP, and just prescribe loperamide. And when to take loperamide, it is 2 grams 30 to 45 minutes before every meal. Okay, this is the treatment pattern. So till now you understand about irritable bowel disease. I have told you functional disorder. I have told you it is a functional disorder which is characterized by any kind of stress on the GI tract, has its association either with the chronic fatigue syndrome, either with the fibromyalgia, either with any of the anxiety disorders, either with gastroesophageal reflux disease. So now the patient has approached to you about this pain and persistent abdominal pain. We will go to our case which I have told you to look at. So in this case, the patient was telling about abdominal pain, persistent abdominal pain, and she said precipitated after the meals, gets relieved after defecation. You have already got a lot of hints from this clinical case scenario only. Okay, and now after taking the physical examination and all and history, the doctors has got everything is normal. Lab finding, CBC, ESR, antibody test, everything normal. Colonoscopy and even the biopsy has been done. It came out normal only. Thyroid profile also normal only. So from this clinical case scenario, doctor must have think about many diseases. So what are the differential diagnoses to this disease, irritable bowel syndrome? First is the colitis, because persistent abdominal pain and a lot of things signifies the colitis also. Colorectal cancer, okay, doctor must have think of colorectal cancer, but here biopsy reports were normal, which has ruled out the colorectal cancer. Another, thyroid dysfunction. Thyroid T2 panel, T3, T4, TSH, T3, T4 and TSH has been checked and it all came out to be normal, so it must be ruled out. Gastrointestinal tract infection, mostly giardiasis. Whenever these symptoms, a patient with these symptoms approaches, we always think of this giardiasis infection. But if there is any infection, there must be increase in the leukocyte count, there must be increase in the ESR or something, in the blood report. So the lab findings were normal. You must rule out from there. It is not celiac sprue and lactose intolerance. The doctor can think of with these symptoms whether the patient is having celiac sprue or lactose intolerance. But here we say, while not to consider the irritable bowel syndrome, I said the symptoms of steatorrhea and malabsorption. It can't be. When the person says, when we get to know the person is having malabsorption symptoms or steatorrhea, it can't be irritable bowel disease. It must be something, any other malabsorption syndrome. Okay. So lactose intolerance, lactose intolerance occurs due to deficiency of enzyme lactase. And till now, how the doctor has approached in this clinical case scenario, everything came out to be normal. So what left? It is just irritable bowel disease only. So friends, if any patient approaches to a doctor with this type of complaints, keep in mind before making the diagnosis, we need to follow this criteria, which is Rome 4 criteria. 3 months, from the last 3 months, 1 day a week, the patient must be feeling abdominal pain. And see, friends, I want to tell you about how significant taking the clinical history is. 70% of the diagnosis is relied on the basis of clinical history and ruling out all the other diseases. So make sure whenever you study any kind of disorder, any disease, any subject, because we have to apply on the daily life, the basic root, the understanding concept must be so much strong that we are able to rule out. Okay, because in India, the country like India, we are not going to keep prescribing or keep telling, okay, go for this test, go for this test, go for this test. And the patient is going to do nothing, just change the doctor only. So keep studying, have a basic idea of this topic, and start solving clinical case scenarios.